Good afternoon, everyone. In the interest of time, we are going to get started with pediatric grand rounds this afternoon. I know lunch is here a little bit later and just getting set up, but let's try and see if we can, with as least disturbance as possible, get that in between the talk. I'm Gayatri Jaishankar. I'm one of the general pediatricians here with the ETSU Department of Pediatrics, and it's really my great privilege and pleasure to welcome Dr. Karen Schetzina with her talk today on adverse childhood events, resiliency, trauma-informed care. Dr. Schetzina has been with the Department of Pediatrics since 2003 when she came to us after finishing her MD and her MPH degree from the University of North Carolina at Chapel Hill, followed by a pediatric residency at Stanford. She has been one of the leading forces in our department, is an academic general pediatrician, heads our division of general academic pediatrics currently, and has really been our force in advocacy efforts for children in the region. Her interests have been multiple and varied. Her CV reads like a book, and she told me, I have lots of information to share today, and so I'm really in the interest of trying to be brief. I'm going to simply say that she has multiple interest publications, starting from breastfeeding to working with children in the community, bringing us all of our great community events and resources, to now working very much with trauma-informed care and resiliency. And has recently been recognized and awarded the Rushton Award for advocacy at a national level at the AAP conference this past month. Dr. Schetzina, we're looking forward to hearing your talk.
Okay, thank you. Welcome, everyone. And feel free to jump up and grab food when it's set up. That won't bother me a bit. So we're going to be talking about trauma-responsive pediatric care. I do have a disclosure. My husband and I own a company called Callian Pharma, which he runs, and I don't think it's related at all to the topic of this talk, but that is my disclosure to you. So I've sort of been a student of this topic over the past several years, so I'm going to share with you what I have learned and evidence that I've reviewed, and then some experience that we've had at the ETSU Pediatric Clinic. So we're going to talk about how adversity in childhood is related to physical and behavioral health conditions, talk about approaches to screening for ACEs or adverse childhood experiences. We'll talk about trauma and trauma symptoms, as well as resiliency skills, and then discuss some basic approaches to ACEs prevention and trauma treatment. And I have been participating in an AAP Project ECHO on this topic. I did a level 1 earlier in the year and am almost done with the level 2, so that it's about 18 monthly ECHO sessions in total. And so some of what I'm going to share with you today, I learned in that ECHO. That is something that is recurring, and so it is an opportunity, if you are interested in this topic, to learn more. It's free. A couple other folks I'd like to mention, Miss Becky Haas, who's now the trauma-informed administrator with Ballad Health, and Dr. Andy Clements, who's a professor of psychology here at ETSU. They have done training with hundreds and hundreds of people, including myself, on trauma-informed care in the region, and actually have developed a resource for communities to become trauma-informed that is published as a best practice online. Tennessee Building Strong Brains is our state's initiative for addressing ACEs and trauma, and we've actually had some funding from that group to do some work around ACEs in the ETSU Pediatric Clinic. And those are the other folks that I'd like to acknowledge, all of our providers and team in the clinic. So in our clinic, we are somewhat unique in that we have a behavioral health and resource team that consists of a staff member who's trained in social work, as well as a faculty member who is a PhD psychologist, and then they have interns or learners as part of that team, and they all work together to help address resource needs and behavioral health needs of patients and families in our clinic. And then more recently, we've added some case managers. We have a registered dietitian that's kind of integrated into our clinic. But this team is unique in that they are very integrated with the pediatric providers and nursing providers in our clinic. So they see patients mainly through warm handoffs. If we identify a family that might benefit from further assessment and services from that team, we just walk down the hall, grab them, and say, hey, could you come talk to my patient? This is what's going on. They'll come in, do further assessment, a brief intervention, provide resources or linkages to referrals in the community, and then kind of close the loop with us in a very integrated, nice way. Of course, they also do follow-ups and consults in our clinic. But as you can see on this slide, over the past decade, the existence of this team and this team initially was established through the work of our past program director, Dr. Becky Powers, and one of the faculty members in family medicine, Jody Palaha, back in 2009. You can see that we've worked on a lot of different projects together, and most recently one of those projects was screening for ACEs. So we've done implemented postpartum depression screening, team care screening, PHQ-9 craft screening, and then most recently ACEs, among other projects. So, and we all recognize now that social determinants have a very significant impact on health and well-being, and that in the context of a pediatric visit, that it's really optimal to address those as well. You know, this provider is so excited that they've treated the ear infection when you've got mom back there who is just really weighed down with issues at school, maybe running out of money for the rent and food by the end of the week. That's going to impact our patient's health. So we have looked at ways for integrating that knowledge and awareness into practice to improve care. So let's just briefly review what are the characteristics of a good screening test, because one of the things we're going to think about today is, should we be screening for ACEs, which I consider to be kind of a special type of social determinant of health. So characteristics of good screening tests, you want to think about, is there a screening test available that has an adequate detection rate, that's low cost, that has minimal side effects? What are the yields of the screening service? Is there evidence that people have improved outcomes if you screen? Does earlier treatment improve the prognosis? So probably most of you have heard about this study that is from over 2 decades ago by Dr. Folletti and Anda and others at Kaiser Permanente San Diego and the CDC. And this study came about because Dr. Folletti observed in his obesity clinic that people were really struggling with treatment, sometimes dropping out of treatment. And he noticed a pattern. And I think this is an advantage that we have as clinicians. If you're interested in research, you can see patterns in your clinical practice that could evolve into a research project, right? And this evolved into a big one. So he noticed that many of his patients had a history of childhood trauma, and teamed up with the CDC to conduct this study. It only included 17,000 adults. And what they did is measure whether or not prior to the age of 18, these participants had experienced any type of childhood adversity in these categories. So abuse, neglect, or household dysfunction. For abuse, we're talking about physical, emotional, or sexual abuse. For neglect, physical or emotional neglect. And then household dysfunction, things like a family member with mental illness or incarceration, substance abuse, mother treated violently, or divorce. So they surveyed these 17,000 participants, and here is what they found. So first of all, over 2/3 of people had experienced childhood adversity. So they had at least one ACE. So there were 10 ACEs counted on that slide there. 16% had 2 ACEs, another 9.5% had 3 ACEs, 12.4% had 4 or more ACEs. And they were able to calculate estimates of specific types of ACEs in terms of prevalence. So for instance, 28.3% reported experiencing physical abuse during childhood. 20.7% reported experiencing sexual abuse during childhood. 10.6% emotional abuse. In terms of neglect, estimates range from 9.9 to 14.8% for physical or emotional neglect. And then household dysfunction, substance abuse was most commonly reported, 26.9%, followed by parental divorce, 23.3%, household mental illness, 19.4%, violence in the home against the mother, 12.7%, and having an incarcerated family member, 4.7%. The other thing that the researchers did is they looked for associations between the number of childhood adversities experienced and outcomes in terms of adult behavioral health, physical and mental health. So what they found were positive associations. So if you had a history of ACEs, you were at higher risk for these outcomes. Lack of physical activity, smoking, alcoholism, drug use, missed work, severe obesity, right? Like Dr. Folletti had observed that association initially in his clinical practice. Diabetes, depression, suicide attempts, STDs, heart disease, cancer, stroke, COPD, broken bones. And so that was really a landmark study that looked at associations between childhood adversity and the prevalence and these adult health outcomes. So since that time, over the past 2 decades, there's been a lot more research that have replicated these findings, that there is an association, and also a dose-response association. So the more ACEs you had, the risk for these conditions increased. So on this slide are some highlights from a Lancet meta-analysis of published research, 37 different studies from 2017. And for instance, if you had 4 or more ACEs, the highest association was with problematic drug use and violence, followed by sexual risk-taking, mental illness, problematic alcohol use, as well as other health behaviors, cancer, heart disease, respiratory disease, and then some increased risk with physical inactivity, overweight, and diabetes. These researchers also found that people with an ACE score of 6 or higher at risk of their lifespan being shortened by 20 years. So, you know, everybody has stress, right? Stress is just part of living. And some stress can actually be positive, right? I mean, I was a little stressed last night thinking about having to give grand rounds today and a little bit this morning, but hopefully that will make me do a better job, right? So, you know, some examples of normal and essential part of healthy stress in childhood: getting a vaccine, going to kindergarten on your first day. Examples of tolerable stress: maybe it's more severe, but it's limited in duration. Loss of a loved one, a broken bone. Stress becomes toxic when it is strong, frequent, or prolonged, and it's not counterbalanced by a caregiver that is providing care, right? So this might be physical or emotional abuse or exposure to violence. When you have toxic stress, it can have impacts in children, and that's also called trauma. So what can trauma look like in children? It could be avoidant behavior, disconnected behavior, being angry and having outbursts, being hypervigilant, right? We've all seen this, I think, in our clinical practice. Well, so what about, you know, impact of ACEs on children? Besides these behaviors that we observe, we talked about effects on health in adults. What about health in childhood? So this is another meta-analysis that was published in 2018, looking at associations between childhood adversity and trauma and pediatric health outcomes. And what they found is that there is an association with increased risk for developmental delay, autism, recurrent infections, somatic complaints, sleep disruptions, obesity. Some studies reported changes in cortisol levels, in immunologic and nervous system functions, and changes in epigenetics, or the way that genes are expressed in the body in response to childhood adversity and trauma. So this is what we know from the evidence. So I mentioned that one of the highest risks, if you have 4 or more ACEs, is increased risk for drug abuse. Thinking about that statistic on the flip side, around 75% of women in substance abuse treatment report a history of trauma or ACEs. So this is certainly a population that we encounter a lot in our practice. So think about that. Most of those women have a history of childhood trauma or ACEs. So, one of the things we want to think about is, okay, we know that ACEs are associated with increased risk for poor health in adults as well as in children. Is this something we should be looking for? We know that ACEs are more common in women, for instance, that are in treatment for substance abuse, but that's certainly part of our patient population. Should we be screening for adults, or screening for ACEs in kids, and what about ACEs in parents? So this slide is about intergenerational effects of ACEs. So what prior research suggests to date is that maternal ACEs are linked to an increased risk for early life adversity in the offspring, in children. And measures of socio-emotional problems of infants at 6 and 18 months show greater risk when mom had childhood adversity. Another recent pediatric study of 363 patients and their parents suggested that with each maternal ACE, the risk for suspected developmental delay and eligibility for early intervention system like TEIS increased by 18%. So for each maternal ACE, that risk increased by 18%. Findings for paternal ACEs were similar. And this is just a graph from that study showing that pretty steep association with maternal ACEs. So just an example of how ACEs can impact intergenerationally. So I mentioned that we are aware of the impact of social determinants of health and have taken steps to kind of integrate that awareness into care in our clinic. One of the things about 3 years ago we started doing is screening with our team care screener. So that screens for social determinants of health. It was adapted from this national study called We Care, which stands for Well Child Care Evaluation, Community Resources, Advocacy, Referral, and Education. That's why they call it We Care. This was a screener that was evaluated in a cluster randomized controlled trial. And what they did with the screener is they asked folks, parents, if they had any, if they had a high school education, if they had a job, if they had daycare, if they had issues with homelessness, food insecurity, hopelessness, alcohol, drugs, or cigarettes. So that's what they asked them. And if they said yes, they said, well, would you like help with that today? These studies were done in clinics that didn't have our integrated care team. They didn't have social workers and behavioral health consultants in the clinic. They had pediatricians and nurses, kind of your more traditional practice model. So what the researchers did is for those different social determinants that I mentioned, they developed just a tear sheet, a handout that had a list of local resources to address that need. And so the screeners were given out to parents. If it was positive and they said they wanted help, they'd be given one of those community resource sheets that was specific to their express need. So what these researchers found is that 70% of mothers who received the We Care screener were referred to one or more community resources compared to only 8% of control mothers, which just got kind of business as usual treatment. So that was a big difference. 1 year later, the the mothers who'd received that We Care survey were more likely than control mothers to be enrolled in one or more community resources and to be employed, have children enrolled in child care, receive fuel assistance, and have a lower chance of being in a homeless shelter. So those were all significantly different in the intervention group that was screened versus the control group that wasn't. So this provides evidence that screening for social determinants in pediatric primary care is effective, right? These folks had improved outcomes. Okay, so I mentioned that these social determinants, and of course the We Care screener that we use in clinic, we ask a few different questions. We just tailored the questions to what we thought the needs were in our population. But you know, those questions, those kind of get at potential ACEs for the child, right? Or potential toxic stress for the child, like food insecurity, severe prolonged food insecurity. And that can cause childhood trauma. There have also been studies looking at children who've experienced ACEs, experienced trauma, and are there interventions that can change the biologic effects of childhood adversity and alter that trajectory toward increased risk for health outcomes. So this is a meta-analysis that was published in 2018 that looked at these trauma-informed interventions. Can it improve things? And they were specifically looking at biologic effects. So they were measuring things in the body. They looked at cortisol levels, for instance, brain development, epigenetic regulation, inflammatory profiles, as well as catch-up growth. So all those things that I mentioned earlier that have been shown to be negatively impacted when there's ACEs and toxic stress present in childhood, this study suggests that trauma-informed interventions can turn those changes around and mitigate the effects. And what they found were earlier intervention, supportive and positive parenting, and greater intervention engagement showed the greatest effectiveness. So, you know, an example of an evidence-based trauma-informed intervention, and there's a lot of different ones that have been developed and studied, but an example is trauma-focused cognitive behavioral therapy. And characteristics of trauma-informed interventions often include developing a therapeutic relationship with the patient, providing psychoeducation, providing both parent and child training. So parent training, again, is an important component of these programs. The provider should have a strong knowledge of child development and be able to address and improve emotional expression, regulation, help manage anxiety, provide tips for relaxation, ways to improve cognitive processing, and then also promote safety of the child to prevent additional trauma. So we've said we've asked folks about their childhood ACEs, and we've been able to measure those, right? And there are screening tools that have now been developed and studied based on those 10 original ACE questions, as well as other potential ACEs, things like bullying and neighborhood violence that weren't in that initial Folletti and ANDA study. And we know that interventions that, like I described, for addressing social determinants in childhood trauma, there's some evidence for effectiveness, right? What about feasibility and acceptability of screening for ACEs? So this study was done by Dr. Gillespie, and when I was at the AAP National Conference 2 weeks ago, I got to hear him talk. He did a workshop on this. So he has a pediatric practice, and he has been screening for parental ACEs in his pediatric practice and doing some research alongside. So they were assessing parental ACEs at the 4-month health supervision visit. And what they found by surveying providers in this study is that they thought it improved the clinic visit, that it wasn't a huge time burden. Parental resistance wasn't an issue. Parents were willing to talk to their pediatrician or their child's pediatrician about their childhood adversity. And like I said, there's some different ACE screeners that have been developed. These folks decided that detection rates were higher with an aggregate level screener instead of item level reporting. So what's the difference between those two? So an aggregate level screener says, okay, before the age of 18, here's a list of some difficult things that some people experience. How many of these affected you as a child? And they write down a total number. Versus asking about each possible adversity one by one and having them circle yes or no. So they found when parents could just report a total number, that perhaps their detection rates of parental ACEs were higher. So what do we know about ACEs in Tennessee? This has gotten a lot of attention nationally and a lot of attention in our state. And as I mentioned, we have a Building Strong Brains program through the Department of Children's Services and state government, and to help kind of mobilize people around ACEs and trauma. So this is from the Sycamore Institute, a February 2019 report, data from 2014 to 2017. They surveyed adults in Tennessee, and what they found is over half reported at least one ACE. So that's kind of similar to the Folletti and Anda study. Remember, about 2/3 of adults in that study had reported at least one ACE. About 17% had experienced 4 or more ACEs. And one thing the Sycamore Institute did is they did a cost analysis, and they estimated that ACEs led to an estimated $5.2 billion in direct medical costs and lost productivity from missed work, just in Tennessee. So through support from the state and this Building Strong Brains program, in 2018, we had some grant funding and built some partnerships with some organizations in the community to do a pilot of ACEs screening in our clinic. So in addition to this published research that I've shared with you, I'm going to add a little bit of information about our experience in our clinic. And again, keep in mind our clinic is somewhat unique. We have this integrated behavioral health and resource team. Not all clinics have that. So this is just an example of what we did in our clinic, but I think we want to think about different practice settings. So, we elected to use an aggregate screener. So the type that I mentioned, Dr. Gillespie found to be a little bit better in terms of detection rate. We decided to pilot screening parents and caregivers for their childhood adversity, as well as having parents answer a child proxy ACE screener, so reporting ACEs for their child in the first 5 years of life. We adapted screeners that are available online through the Center of Youth Wellness by Dr. Nadine Burke-Harris. She's actually the first Surgeon General of California now, that has done a lot of work in California around ACEs and has made all her materials available online to download. So we use the Center for Youth Wellness screeners. One of the things about the screeners that were available that bothered our providers is if you're screening for ACEs in children, you may be asking parents and caregivers to tell you about potentially reportable issues that may be ongoing, right? Like child abuse and neglect, and we're obligated to report those to the state. And so one of the ways we adapted these Center for Youth Wellness screeners is on the blue one, which was the screener about the child's ACEs, is we simply stated that at the bottom, that we're required to report any suspected abuse or neglect. So please answer these 2 questions, yes or no, so that we would have a better idea if that's something we needed to be concerned about and nothing would get missed. And that actually worked well for us. So I'll read these really briefly. If you've never calculated your own ACE score, you can just do that in your head if you want to. So these are the things that we're asked about on the ACE screener. So you want to think about experiences prior to 18 years and give yourself 1 point for each question you answer yes to, up to 10 points. And then we had them just report the total number. So number one, your parents were separated or divorced. You live with a household member who served time in jail or prison. You lived with a household member who was depressed, mentally ill, or attempted suicide. You saw or heard household members hurt or threaten to hurt each other. A household member swore at, insulted, humiliated, or put you down in a way that scared you, or a household member acted in a way that made you feel afraid that you might be physically hurt. More than once, you went without food, clothing, a place to live, or had no one to protect you. Someone pushed, grabbed, slapped, or threw something at you, or you were hit so hard that you were injured or had bad marks. Someone touched your private parts or asked you to touch their private parts in a sexual way. You lived with someone who had a problem with drinking or using drugs, where you felt unsupported, unloved, or unprotected. So pretty heavy stuff. You know, of course, when you're asking adults about these experiences, they've already happened, right? In a lot of cases, they've happened, you know, some time ago. Of course, when you're asking parents about their children's ACEs, these things may be ongoing. And I think you've got to do this in a sensitive way, in a way that you're open into listening and hearing what they have to say, and in a non-judgmental way. So our team in the clinic developed this educational handout that we distributed with these screeners. And the screeners were given to parents and caregivers at the 1-month well-child visit, and then parents were asked to report on their child's ACEs at annual well visits 1 to 5 years of age. So they got this handout that explained about ACEs. It also talked about ways that you can build resilience in your family with these 5 protective factors. And it included a list of local resources. So they got that to read over. And I will say the 5 protective factors, we made sure there were some very practical tips in there for good things they could do with their family. And then as part of our grant-funded protocol, we had some additional resources to offer families. And these were in the form of parenting, education, and support. So you can imagine if you were a parent that had experienced a lot of childhood adversity, when you become a parent, that's one of the major kind of contexts for being a parent, right, was your own experience. And so in those cases, sometimes some additional resources and support might be particularly beneficial. So we offered these 2 evidence-supported programs. One's called the Incredible Years, and that was delivered by our BART team members during infant well-child visits. And then we also offered referral to a community program of home visits with the regional health office and Families Free. And that was called Nurturing Parenting. And this was in addition to the assessment and resources and interventions and referrals that our behavioral health and resource team provides anyways, okay? And then 2, we had in our clinic these programs, Reach Out and Read and Play for a Bright Future, that if you think about it, provide families with additional resources and opportunities for strengthening their family and building resilience in their kids, spending time together in positive ways, reading, playing together. So we actually added a prompt in our EHR to remind us in the context of ACEs screening, be extra sure that you've given these resources to your family that have ACEs, okay? Because they might be particularly useful for them. Of course, we try to give it to everyone. And one of the things that we found particularly useful, particularly when thinking about a history of parental ACEs, is to open the conversation with, you know, I'm sorry that happened to you. Thank you for sharing that information. We want to help, you know, provide the best care for your family and your child as possible. How do you think those experiences are impacting you now? And that was kind of a good way to figure out what direction to take the rest of the conversation. Here's briefly what we found. So twice as many of our parents and caregivers had an ACE score of 4 or higher than is reported for Tennessee adults as a whole. So we found that parents and caregivers in our clinic, and again, we're screening at the 1-month well-child visit, 37.5% reported an ACE score of 4 or higher, compared to 70% of adults in Tennessee. And then children, also, in the table, I won't read everything to you, but there were also reports of ACEs in children. These were young children in the first 5 years of life. We also, several months later, did some follow-up surveys with parents after ACEs screenings, and we looked at, using a kind of validated questionnaire, their ratings of acceptability, feasibility, and appropriateness of ACEs screening, both child and parent screening, during the pediatric visit. And it was very high in this sample of parents that we surveyed, that they found it acceptable, feasible, and appropriate. So that was our experience and evidence that we collected with our pilot ACEs screening project in our clinic. We are actually not currently screening systematically for ACEs in our clinic, although we still use, of course, the team care screener that screens for some risks at ACEs. And at this point, we're kind of rethinking, how do we want to do this? Our pilot, and it's always good to start small, I think. We just did with a couple of providers, my patients, Dr. Jaishankar's patients, and then some of Dr. Gibson's patients and residents in those continuity clinic. And so we're kind of at this point thinking, well, how do we want to use all this experience and information to serve our patients? And so we're going to talk through a case, and I'm going to share with you some things you can think about, regardless of your practice situation or your future practice situation. How could you address ACEs and trauma in your practice? And I will say, Dr. Nadine Burke-Harris, who I mentioned, authored the screener that we adapted, and who's now the first Surgeon General of California. She has worked with the state legislature and state government, and they've now allocated funding for their Medicaid program to support training and ACEs screening and screening in children and adults statewide in California. In Tennessee, we're actually part of a program with our Bureau of TennCare and our Medicaid providers, which is also trying to promote screening for ACEs, and that's called upper payment limit. So there's interest around the country and in here. So let's look at this case in the last kind of 10 or 15 minutes. Previously healthy 4-year-old Jimmy presents to your office with his mother, Pam. During the past 3 months, she reports that Jimmy has had trouble sleeping, is having screaming fits at the dinner table, and is yelling and hitting his younger sister. So this is a mnemonic that I was taught in the AAP Project ECHO on trauma and resiliency that I'm going to share with you. And it is a mnemonic to help you think about common symptoms of trauma. You are frayed and at the end of your rope. So you can manifest trauma in fits, frets, and fear, have difficulty regulating your emotions, through attachment disorders, having strong and healthy attachment for a parent, with a parent and caregiver, or a trusted adult in childhood, is really important. Yelling and yawning. So again, that sleep disturbance can be a symptom of trauma. As we mentioned before, educational and developmental delays. And then being defeated, or kind of that sense of hopelessness or depression. So in our case patient, he's certainly displaying some fits, frets, and fears, as well as yelling and yawning, right? And it would be good to think about assessing potential symptoms in these other areas. If you do further screening for ACEs, you learn that Dad has actually been incarcerated since the last yearly well-child visit. He was incarcerated on drug charges. He's recently been released and is back in the home. But because of Dad's incarceration, money has been really tight. The parents are having lots of arguments. So how could this possibly tie in with what's going on in terms of the presenting complaints with the patient? So let's go back and talk in a little bit more detail about brain development. So normally at birth, the brain is underdeveloped. Not all the brain's areas are organized and fully functional. During childhood, the brain matures and develops in sequence. So we crawl before we walk, we babble before we talk. And the process of sequential development is guided by the baby's experience, right, and interactions with the environment. The brain develops and modifies itself in response to experience. So in terms of interactions with a caregiver, this is often referred to as serve and return, kind of cause and effect. I do this and this happens. And the brain actually modifies, the neural connections in the brain actually modify and grow based on experience. And the areas of the brain that are used more get stronger. The areas of the brain that are used less don't develop as much. So what happens when there is trauma and toxic stress? So you can have excessive and prolonged activation of the stress response systems in the body, in the brain. And again, if you don't have buffering protection from an adult caregiver, this can have a lot of negative impacts. And so people have studied this with MRI and blood tests and genetic testing and other measures and found that impact occurs in three main areas. So in brain connectivity, in immune function, and in epigenetics. If you think about reactions to stress that could be beneficial if you were being chased by a bear while you were hiking, right? Freeze, which, there's all that stuff on the internet about what you're supposed to do when you encounter a bear. I don't know how you decide that at the time, but fight, flight, or freeze are three of your stress responses. The problem is, while that may help you when you're facing a bear, if you live in that state all the time, day after day, those become maladaptive, right? Fighting, fleeing, and freezing. Those become maladaptive. So, and they can be misinterpreted when you don't think about it in the context of past trauma. It's important to ask and think about what happened to you, what happened to your patient with these symptoms, not what's wrong with this kid who's fighting with his sister and not sleeping. Consider what are relationships that can help, hurt, or heal. What happens with trauma is you get stuck in the lower brain, in the amygdala, for instance. You stay there. That's the part that becomes the stress response center. That's the part that you're living in day to day when you're experiencing toxic stress. And that part of the brain's developing, whereas the connections in the cerebral cortex are not developing as well. That's why you see developmental delay. And you end up with a negativity bias. And this is how children with experience in trauma live. I'm in danger, I'm worthless, I'm powerless. You, my mom, my dad, are not reliable. You cannot protect me. You will be dangerous or rejecting. And trauma limits your ability to self-regulate, to describe your feelings, and your ability to communicate wishes and desires. So again, can significantly impact development. So again, what can happen with trauma? Your thinking and learning brain shuts down. Hope seems lost. Regulation or self-control shuts down. Efficacy is lost. Attachment may not be available. Your skill mastery, learning, again, is shut down because you're stuck in the lower brain. And then social connectedness. You feel this hopelessness in the sense that you're alone with this threat. It's just happening to you and nobody else. The good thing is that when positive experiences outweigh negative experiences, a child's scale can tip towards positive outcomes. So we know as pediatricians, children are naturally resilient, right? They bounce back from things in ways that an adult does not. So what is resiliency? Here's one definition. A dynamic process of positive adaptation to or in spite of significant adversities. It can be applied to a child, a family, a system, a community, or an ecosystem. So positive adaptation in despite of significant adversity. Few facts about resiliency. It is not rare. It does not result from extraordinary talents or resources. Some people refer to the development of resiliency in children as everyday magic. just being a kid and having those normal, healthy childhood experiences. That helps kids become resilient and stay resilient. So resiliency develops through safe, stable, and nurturing relationships that are continuous over time, and through growth that occurs through play, through exploration, and exposure to a variety of normal activities. Now, an attachment, positive attachment relationships with the primary caregivers are very important. And again, this resiliency develops in the context of these positive serve and return relationships. So a sense that your primary caregiver or your parent provides a safety, a safe haven, and they see their parent in the world as safe and predictable, maybe because the parent has routines and some rules, and they're consistent. Emotional regulation, that the parent can help dampen their stress response, can help the child calm down and restore a feeling of security. That they have a secure base for exploration. So think of toddlers. When they start to explore the world, they'll be with their mom and they'll run away and then they'll get scared and they'll run back and they'll do it over and over again as they learn to explore the world. Sense of self, that they can see themselves reflected back by the attachment figure. And then executive functioning, decision making, learning, that is modeled by the caregiver and eventually integrates into the self. So one more acronym for you, and it's the Resiliency Threads of Childhood. So these are things that you want to assess, and in our case patient, we want to touch on these areas with the parent caregiver. Everyone has some resiliency, right? Everybody has positive things about themselves and about their life and their circumstances, and you want to note those and build on those. And again, these can also be targets for intervention. So thinking, learning brain, that sense of hope, regulation or self-control, efficacy, a sense that I can do it. Attachment, again, that relationship with the primary caregivers, developmental skill mastery, and social connectedness. Even outside the primary caregiver, is there a social network and connection that can help support that family? So again, these would all be important things to assess with our case patient, and they provide some things to work on. So back to the issue of screening for ACEs and trauma and resiliency, you'll want to think about, in your practice setting, what are your goals? Do you want to look for risk factors, like for instance with our team care screener? Do you want to screen for symptoms of trauma? Remember that FRAID acronym. How can you differentiate trauma from other diagnoses? So we have the luxury of bringing in our behavioral health consultant to help us tease those things out. But of course, trauma can overlap with a lot of different conditions, as we've talked about. And what information about ACEs do you already have from developmental screeners, depression screeners? In our clinic, we screen for postpartum depression in moms, and we've been doing that for many years. That's a potential ACE for the child. Behavior screens and other things that are routine to your practice. And then you'd want to think about, who do we want to screen? Do we want to screen for ACEs in our children, our patients, and caregivers, and the family, what's available in the community? Of course, common concerns: is this going to lead to patient or parent distress? How's it going to impact office flow? And then what are you going to do with your screening results? And I think that's one very important thing. If you screen, you want to have a plan for assisting families, and think about what that looks like in your practice environment. The other thing you can think about is our typical, or maybe our enhanced, social history and review of systems is an opportunity to ask lots of questions about trauma. So since the last time I saw you, has anything really scary or upsetting happened to you or anyone in your family? Are there any behavioral problems at home or at school? Any changes in your child's mood or personality? Has anybody come or gone from the household lately? Is your child having trouble with sleep or on uresis? Has your child ever witnessed anybody being harmed at home or in the community? So ACEs screening can be done, and trauma screening can be done with screeners, but it can also be done in the context of taking a good history. So think about ways that maybe you're already screening for ACEs and ways that you can enhance your conversation, knowing what we've talked about. Some of the formal screeners that are out there that I mentioned, the ACE-Q is the one that we pilot in our clinic. And then Dr. Gillespie, who I mentioned, does have his parental ACE screening tool published online that you can use. There's also a really nice cover letter, and we adapted some language from it that kind of introduces the screener to the parent. And why are we asking these questions about you when we're your child's pediatrician? There's, of course, other social determinant screeners out there besides that we care. And there are screeners that can be used for trauma that are validated. All right, back to our case patient and just some ideas for approaching treatment. We're suspecting that our case patient may be experiencing some effects from ACEs, right, and trauma. We want to talk about how to foster predictable, compassionate availability, and the 3 R's, which stand for reassuring, restoring routine, and regulating. So this predictable, compassionate availability, things that we could talk about or coach or perhaps refer mom for some parenting education or the family for some counseling, things that they could do that would help this child. They want to try to tolerate strong emotions. Know that the child may be acting out, but their emotion is not about you. You've got to remember and learn that, and that will help you to respond more calmly. Help the child name their feeling, right? This is something that children with trauma have difficulty doing, but can help in terms of getting a hold on their behavior. And then that reassurance, establishment of routines and regulations. So reassurance, caregivers, if they can model calm behavior despite the stress, that will help. And I've seen some foster parents that do this so amazingly well. I see that in our clinic when they come with kids and they're having acting out behaviors, that they stay calm. And that will help diffuse and reassure the child. Routines can help communicate safety and help shut down the stress response. So talking to parents about routines and what those might look like. And then helping a child regulate their emotions is going to look different depending on the child's age. Like the 4-year-old may appreciate a hug. That may really help to them to regulate their emotions, whereas a teenager might not want to be as huggy, right? So you got to think about what it looks like at different developmental levels. Continued positive interactions can lead to restoration of resilience skills. So these are things that we could talk about with our case patient family. They also, it sounds like we could help connect them to some resources for finances, right? And food, maybe they need more help with drug counseling or family counseling, those types of things. But these are some things we can talk about that can help the behaviors that they're seeing with their child. And again, there are going to be some children who need those evidence-based trauma treatments that I mentioned have been shown to be effective. Some final tips. If you think trauma may be the cause of symptoms that your patient is having, you can talk about it with your caregiver. Say trauma may be the cause. You want to speak at a level that is appropriate for the caregiver and the child. It's probably something the parent's been thinking anyways or wondering anyways. You want to make sure that caregivers feel safe and feel comfortable. A lot of times it's helpful to do this in a room in our clinic where there's toys that the child can play with, or there's tissues available. You want to problem solve to help right now, right? Or there's some things that you can suggest that might help make mealtime go a little bit better, things they can start working on to make sleep go a little bit better, while you continue to investigate further and work on some of these harder issues. Watch for reactions during the discussion, slow down or back up if the caregiver becomes confused or look upset. Listen openly and let the caregiver tell you about feelings and worries. And refer for treatment when indicated. And I think you've got to approach these conversations as being a good listener and being empathetic, and you're not just going to fix everything, right? Role of providers. We can promote resilience in each and every encounter. Again, be an attentive, attuned listener. Try thinking about those Threads and FRAID acronyms when you're seeing patients, and offer some guidance and support that we've talked about. Activities that can foster resilience. So quality childcare, getting kids into pre-K may be really helpful, might be helpful for this patient. Reading with patients, or with children. We sometimes read with our patients in the lobby. Interactive play, attentive listening, storytelling, singing. You always want to consider the child's age, temperament, and development. But again, that everyday magic. And then identification of community resources. So the Centers for Disease Control has outlined many of those things that I just mentioned that can help ACEs into a model for communities to prevent and lessen the effects of ACEs. Some resources, so Sesame Street and community. Sesame Street has lots of nice resources. So children's books that are kind of tools for parents around difficult topics like incarceration. They've got mobile apps like this Comfy Cozy Nest that can be great tools for families or for you to show parents that they could use with their children. The American Academy of Pediatrics has the Resilience Project. There is also a new initiative called PATTER that we'll probably be hearing more about with tools. And again, mention that Trauma and Resilience Echo, and if anybody's interested in that, I can connect you to the contact person for that. The National Child's Traumatic Stress Network has information about trauma screening and screeners, as well as other resources. And then ACEs Connection and this Growing Resilient Communities is a guide that was actually developed locally that's kind of highlighted as a best practice from Dr. Clements and Becky Haas. So, it's 1:01, so I did it. But I didn't leave a lot of time for questions. I'm happy to answer any questions now, or if we run out of time, I'm happy to stay after. You can clap.